Just here in South Florida. I had the pleasure of seeing the work Ben and Daphna and Rooney have been doing over the years, and I wholeheartedly compliment them for all their efforts. Like many here, I went into neonatology because it was a very innovative field. And here we are talking about daring to be innovative. And I have a very big insight to share with you. Okay, you ready for it? You ready? Okay. My feeling is that the biggest opportunity for innovation today is not in the NICU. I know that's hard to grasp, right? Because we're so used to being confined with our four walls. But let me share with you a little bit why I feel this way. First of all, I don't think we're going to be saving infants of a younger gestation than we already are saving. And I think that we are already having children who are different character than we used to have when going home. Like you, we all have sent infants home like this with parents who look like Rambo, more than a parent, with oxygen on one shoulder, some 1980s monitor on the other, and some suction on the other hand, and some child looking really inquisitively like, what the heck is going on? And we know this gut in our feeling when we send these families home. We have a gut feeling, this doesn't seem right to me. I wouldn't want to be in this situation if I were those parents. And we know the outcomes. We know the literature, what it shows. We know that at least 1% to 6% of infants we send home who are high risk are dying, as Dr. Vora has showed us, with a wide intra-hospital variability. We know that there's huge readmission rates, at least a third for high-risk babies with ongoing huge expenditures. So these children are not graduating from the NICU. They're just transitioning into a whole new chapter, which is often more difficult than the one beforehand. We already are sending parents home with some tools to mediate these risks, and they're actually increasing. We're sending at least over half of our infants with BPD home, as Dr. Legata showed us, on oxygen. And now we're even sending more infants home with nasal gavage tube feedings, as Dr. Legata also showed recently. And in a really interesting, amazing article that I suggest you all read from 2017, it was Dr. Kuo that really broadened my horizons, was an article that detailed how the current system that we're using is not working, that it's just totally not working. And if that was not enough, next year I read from Dr. Vore a mind-blowing study demonstrating how with social tools alone, when sending a child home from the NICU, by supporting them with a matched parent and giving them tools and resources of what to do in case of a need, they're able to provide $18,000 worth of Medicaid savings. Remember the other slide, the total yearly was over $36,000. On top of this, looking at the industry as a whole of healthcare, I saw something else that was ongoing, which also blew my mind and made me very frustrated, was I was seeing for the adults, we have this concept of hospital care at home, and it was growing and growing, and I see these articles about companies raising millions, hundreds of millions of dollars for adults with chronic conditions, adults with chronic consumers of healthcare resources, and no one was thinking about our population. As usual, we're sort of on the side and sort of left behind. But the reality is we spend a ton of money, we spend billions of dollars for keeping kids in the NICU, and we have no tools like this when sending patients home. So I came to a reality, which is we already have a NICU at home. We have one, we can't deny it. We're just not providing it in a structured manner, and we're putting all the burden and responsibility on underprepared and overwhelmed parents. So me being who I am, I decided to try to go out and fix this problem, and I started making First Day Healthcare, which is the first tech-enabled platform to try to extend the care we provide in the NICU into the home. I built it using wireless remote patient monitoring, as I'll show you a little bit in the next slide. And not just monitoring for an acute deterioration, I also have vital sign analytics. I'm able to collect data second to second and collect even hero scores on babies, where we could even have a higher level of analytics for patients in the home than I'm provided when I take care of a baby in the NICU. We incorporated it with modern telemedicine tools, care workflows, and digital healthcare record tools as well, to really try to match a level of care, if not higher, than our feeder growers are already receiving inside of a hospital. The tablet looks like a hospital monitor when the patient is in the hospital. As you could see, the flowing of the ECG, the saturation data. We also have not just that, we also have continuous skin temperature and an axilla temperature, something that feeder growers, we don't have monitoring, continuous temperature monitoring. I could talk to you later if you're interested about the devices we're using. They're all FDA approved and industry's lightest and smallest possible that are out there. And we also have other tools such as scales and examination devices. And then I was saying, with the click of a button, the tablet turns into a tool for providing care in the home. So the vital signs are at the top. And then you have the ongoing care with medications, feedings that the parents should be giving the baby, the way they could continue tracking the growth of the baby from the NICU into the home. And literally the parents just receive a text. If we want to change the care, the doctor wants you to increase this, press 1, you accept, press 2, you have a question for increasing the feeding volumes. And everything that we see from the tablet, we see in the back end. We have all the vital signs flowing, second to second, tracking the vital signs. And I didn't show a slide, but again, to show we could track the compliance of the medications, the ongoing nutritional components. Everything you would find in Epic, but I could guarantee you much less clicks and a much more simple format for friendly use for physicians. We also have mobile applications. We have an application for the parents if they're not next to the baby at home, next to the tablet. We also have an application for use inside of hospital 4 walls. So that's a little bit about our technology, but the technology is encompassed by care for hospital at home that also has a command center where we're monitoring, analyzing vital signs, and to be able to provide the daily care for these feeder-grower infants and to support parents as needed. And lastly, home visits for point-of-care testing or delivery of therapies, or something as simple as replacing an NG tube that came out. It doesn't require you to go to the ER to have an NG tube replaced in the middle of the night. So overall, our goal is to create and provide a whole new alternative model of care delivery for former premature feeder growers that is based in the home. It's going to offer a seamless transition of care utilizing a more gradual weaning of therapies. I strongly feel that we stop caffeine too quickly. We push kids off of oxygen because we want to have lower BPD rates. And then we're stuck with the gavage tubes, and now we're even sending them home with gavage tube feedings. And my goal is to not stop the caffeine, do not stop the oxygen, do not stop the NG tubes. We'll provide a better oversight and gradual weaning of these therapies for the child into a normal child physiological transition. And most importantly, no more DSAP Brady spell watches. I don't know about you guys, but I find it very frustrating that such an academic field utilizes such a low-tech and tool that I don't know. I mean, everyone probably has a protocol on their wall somewhere. DSAT this equals 3 days, DSAT Brady equals 5 days. I hate them. And clearly, if it worked, we would have no readmissions and we would have no mortality. So it's not, it doesn't work, it's broken. So that's our goal, is to offer significant savings along with peace of mind to parents. Along my journey, I found different use cases before providing care in the home. As you heard earlier, wireless monitoring is a way in the future. We have struggled keeping leads on pediatric patients. We have lots of false time on alerts, decreased mobility. And also, it's just a monitor. It doesn't tell you early actionable insights. It just tells you if a DSAT is happening, et cetera. So we have some ongoing projects. We're working in a step-down facility in New York. It's a 100-bed inpatient rehabilitation center. They have also a nursery unit. They take children from NICUs that NICUs couldn't get home themselves. And every patient in this facility is connected to some type of monitor. They're connected to a pulse oximeter, you see on the right, size of a shoebox, has a wire. Everywhere they walk around, it's like a ball and chain and beeping and so on. And then you can see our tablet with the same numbers and some initial data showing a strong correlation between our numbers and their numbers. The other thing that we've come across is for normal newborns. Probably aware about sudden unexpected postnatal collapse. It's when a normal term infant is found in a clinical state of deterioration who's needing CPR. And it's synonymous with an accidental suffocation or asphyxiation. And as we know, one of the largest risk factors is breastfeeding skin to skin. How do we correlate and how do we work together with baby-friendly initiatives that are trying to push and encourage skin to skin and breastfeeding? And I'm not here to say not to breastfeed and not to do skin to skin. I'm just observing the data that it is a known risk factor for SUPC. So how do we correlate the two together? Well, what's happening to these infants with SUPC? At least half are dying, at least a quarter are neuroimpaired, and a quarter are normal. It just depends when you notice it. If you notice it soon enough, it's just an ALTI. If you don't notice it soon enough, they could be HIE, and if they're noticed too late, they're dead. How often is it happening? It's definitely underreported in the literature. There's a wide variety of incidences reported from 0.3 to 13 per 10,000. But if you compare it to other conditions that we treat or monitor for newborns compared to GBS or PKU, hearing loss, critical heart disease, or HIE, they're actually very similar to conditions that we're monitoring or managing in the newborn nursery. What's ironic is infants already wear some type of technology. As you can see on the foot, the infant hugs for infant abduction actually occurs less than SUPC. So you'll know if your baby's being stolen, you just won't know if they're dead or not. So the reality is we have thousands of babies every year in this country who die or permanently brain damage due to accidental suffocation. And the ironic thing is there are already recommendations from AWAN that in the first 2 hours of birth, while doing skin-to-skin or nursing, they should be monitored. But there is no current product or offering to enable this, and it's not widely practiced. We have an ongoing study that we're starting at Cleveland Clinic. We're also working on a way to integrate wireless monitoring of a newborn in the parent's room, so you could have eyes and ears of the baby in that room and know that everything is fine. So if the biggest opportunity for innovation is not in the NICU, where is it? Well, in my opinion, it's how we use technology to take the care home and postpartum room to decrease unnecessary utilization and parent separation. My call to action is to discuss and find other leaders in our field who would be interested in providing NICU at home or NICU in your room with trials that are powered by First Day Healthcare. I don't have any swag or Ford items to give away, but if you are interested, please come find me and be happy to talk. If you are continuing to Orlando for AAP, please come find me as well in the vendor booth that we have at 1031, and you can find my email and website there. And thank you very much.